Hello and welcome back to the Oncology Brothers podcast. I'm Rohit Gosain, here with my brother and co-host Rahul Gosain. Today, our focus is diffuse large B-cell lymphoma, DLBCL, one of the most aggressive yet potentially curable lymphomas with the right approach. To help us navigate the latest data and evolving treatment landscape, we are thrilled to welcome Dr. John Leonard, a renowned lymphoma expert from NYU Langone Cancer Center. John, thanks so much for joining us.
Thank you. It's great to be here with you today.
John, first off, congratulations on your recent promotion. Now you're overlooking the whole hemonc department at NYU Cancer Center. Welcome. Rohit, you started us off with the diffuse large B-cell lymphoma being aggressive, but yet curative. That said, when we have relapsed refractory disease, our outcomes are still poor. We'll get to that, but John, can you briefly start us off with your initial workup? Is everyone getting bone marrow biopsy upfront if you're working with this diagnosis, or is PET-CT good enough? What about NGS to confirm the origin cell story, be it GCB or ABC type, as this will also come up when we're talking about Polatuzumab?
Right. I think that, so a couple of things. Basically, diffuse large B-cell lymphoma is typically presenting with an enlarged lymph node or multiple enlarged lymph nodes. It can have extranodal disease in lots of different sites. The median age is in the range of 65 years old. We have had for several decades the IPI, the International Prognostic Index, age, performance status, LDH elevation, extranodal disease in more than one place, and stage 3 or 4, all adding up from 0 to 5 prognostic factors. And really, until recently, we didn't treat patients any differently on that basis. When I see a patient, I am getting labs, CBC, LDH, hepatitis serologies. When you're thinking about rituximab, HIV testing, serum immunoelectrophoresis, you want to make sure that you have a good biopsy, whether it's a good core needle biopsy. FNAs are often insufficient. And then a PET scan, as you noted, is really, I think, the staging test of choice. Higher SUVs arguing for more aggressive histologies like DLBCL, lower SUVs arguing for more indolent lymphoma. I very rarely do bone marrow biopsies these days. I think they really don't change management at this point. We're seeing with more and more lymphomas that if they're PET negative after treatment, the bone marrow is likely to be responding as well. And so whether or not the bone marrow is involved at baseline doesn't make a huge difference. I think more and more centers are doing molecular profiling and mutational analyses. Those really have not translated into changes in outcome. We'll talk a little more, I'm sure, about Polatuzumab and what we think is more preferential or maybe more preferential activity in the activated B-cell subtype or non-germinal center B-cell subtype. I think many centers are doing immunohistochemistry, the Hans algorithm that looks at a couple of different markers and says germinal center, non-germinal center. That's a reasonable surrogate. So I think there's not a lot of actionable mutational findings at this point, but hopefully that will change. I think that's certainly lagging behind many solid tumors that the audience is well aware of, where you might find a targeted treatment option on that basis.
Thanks so much for summing it up, John. With regards to stage 1 and stage 2, we have been very frequently using RCHOP, but now with Pola-R-CHP, where exactly are you using this in stage 1, stage 2 settings, and how many cycles?
Historically, limited stage disease was treated with CHOP or R-CHOP, followed by radiation, typically after 3 to 4 cycles of treatment. We've now moved towards a more PET-adapted approach. If the PET is negative after 3 cycles of therapy, then abbreviating the therapy, typically 3 or 4 cycles, and holding off on radiation treatment. If the disease is PET positive after 3 cycles, there's more debate on what to do, but most of those patients would get radiation and probably more chemotherapy. It's hard to do randomized trials in the PET positive group because most patients are PET negative. The addition of Polatuzumab is interesting in a couple of settings. In the limited stage setting, we don't have a ton of data on the Polatuzumab RCHP with abbreviated treatment, although that would be intuitive that if you were abbreviating therapy, you might if Polatuzumab offers advantages, particularly in the non-germinal center subtype, in a limited stage patient, you might swap in Polatuzumab. Interestingly, the Pola-R-CHP study, which established Polatuzumab RCHP as a standard for advanced stage diffuse large B-cell lymphoma, did include about 10% limited stage patients. And so you could argue that if you had a limited stage patient who had an IPI of 2 or greater, you might use Polatuzumab in that basis based on the Pola-R-CHP study. All of those different options are probably reasonable. I don't know that we have a definitive answer, but it would certainly be reasonable to use Pola-R-CHP in limited stage patients as well, although the rigor of the evidence is a little bit more limited.
John, thank you so much for touching on this. Now let's focus on stage 3 or stage 4 disease. I know we're moving through this quickly, but the bulk of our discussion is going to be here, stage 3 and 4 disease, and what if the disease is refractory relapse. I know we've touched on Pola-R-CHP, Polatuzumab already, but we're going to see this here again because Pola-R-CHP has been the closest in changing our standard of care with R-CHOP. But the big debate here is this really beneficial for all comers, given the data supports that strongest evidence is for non-GCB type? John, today in your clinic, outside trials, what's your go-to first-line treatment in a patient that has good performance status?
I think I would say that most patients are getting Pola-R-CHP. The bottom line, as you alluded to, is that the study enrolled essentially all advanced stage patients with IPI 2 or greater, regardless of subtype, and was a positive study. With more follow-up, now we have about 5 years of follow-up, and I would say the progression-free survival benefit is an absolute difference of about 6%. It makes a difference for 1 out of 13 or 14 patients. At the end of the day, it's a positive study across the board, and there's not really extra added toxicity of the Polatuzumab. There's not really major additional neuropathy. There might be a little bit more neutropenic fever, but really similar outcomes. Some people would say, look, if it could help all subtypes, give it to everybody. However, there have been subgroup analyses and other studies that have argued that the benefit seems to be more enriched in the non-germinal center subtype or the ABC subtype using different surrogates and different assays and different patient populations. The takeaway message is if you see a non-germinal center subtype patient, you definitely want to use Polatuzumab. If it's a germinal center subtype, perhaps a little more debatable, and I think either one is certainly reasonable and probably not going to make a huge difference.
And the space is getting more and more exciting because we are seeing some clinical trials with bispecifics being tested in frontline, though that's not an approved option. Where they're still approved are in third line and beyond. We will get to bispecifics shortly, but still focusing on frontline setting where if the patient is frail, an option then is mini R-CHOP as a preferred option, or in some case, utilization of mini Pola-R-CHP. And if someone has compromised ejection fraction, our options are RCEOP or RCEPP or dose-adjusted EPOC. Anything to add here, John, before we jump on to relapse refractory settings?
No, I would just say that this group of patients, I tell patients, particularly the older and frailer patients, that they rarely finish with what they started with, meaning you have to prepare to be the artful oncologist and not get on a train that the patient can't change. Often you start, with a lower regimen like mini R-CHOP, and then you might escalate if the patient tolerates it well. On the other hand, you might start with a full dose R-CHOP like regimen and then de-escalate if the patient doesn't tolerate it. So these patients often go up and down. And I think the key thing is to really tailor how the patient is responding. You obviously don't want to cause the patient a life-threatening complication. Also, I'm sure the audience is familiar with some of the pre-phase data that you can sometimes give some vincristine or prednisone to kind of ease the patient into therapy. I think that's also a good approach, particularly if the patient has a poor performance status. You can get the disease under a little better control without putting them at high risk, remembering that the risk of major complications tends to happen in the early cycles of treatment.
Indeed, the art of oncology and patient-shared decision-making certainly is the key here, or in any other aspects of cancer. Rahul, as you touched on this, roughly about 1/3 have relapsed refractory disease. And in those settings, options are if it is less than 12 months, then utilizing CARTT approach, can we take a minute here to talk about CAR-T, as the data continues to show that good amount of patients who even qualify for CAR-T can't even make it to CAR-T. And a lot of it has to do with logistics, as this is rather an inpatient treatment. But just at this past ASCO, what we saw was Axisel being given in outpatient settings, and safety profile looks good. I'm hoping CAR-T will make its way to outpatient setting. We'll see how that turns out in future. John, floor is all yours with relapsed refractory disease, sir. How are you maneuvering through your CAR-T options here and other potential options present?
So I think the key information here is that if a patient is chemo refractory, giving them more chemo and doing an auto transplant, which is more chemo, is not going to work well. If you're refractory to lower or intermediate doses of treatment, giving a higher dose of the same thing is not going to work well. That's why we have randomized data suggesting that CAR-T offers a benefit, including an overall survival benefit. However, if the patient took a longer time to relapse, they had some element of chemosensitivity, even though they relapsed, giving them more chemotherapy may have a benefit, including autologous stem cell transplant or other chemotherapy-based approaches. The 12-month mark is arbitrarily chosen to represent chemo-resistant or chemosensitive. You can argue that someone progressed at 13 months versus 11 months, is that really different, et cetera, et cetera. And so sometimes people are pushing in one direction or another based on that. The evidence for CAR-T makes a lot of sense in the chemo refractory group of patients. We have Axisel, Lysel. Those are the treatments of choice. Whether or not the patient needs bridging therapy with some sort of chemotherapy-based approach in between is a clinical judgment. Certainly is not something that's required, but if the patient is ill and needs something to bridge them over, then that's certainly an option. One takeaway for CAR-T and lymphoma is that if you're planning to collect T cells for CAR-T therapy, you don't want to use bendamustine early. So if you're thinking about CAR-T, the Pola-R regimen would not be your treatment of choice right before collecting T cells. So do keep that in mind if CAR-T is a near-term option for your patient. For patients who have later relapses, there are a number of options listed there. Chemotherapy, one of several second-line regimens, moving to auto transplant. You can look at Pola-R, you can look at Tafalen. Those are typically used more in older patients or patients who are not going to be candidates for more aggressive approaches. And then as you move down the line toward the right part of the algorithm, you see that we have bispecific antibodies and CAR-T as a later line approach as well. So I think my takeaway is that you have to decide, is the patient going to be a CAR-T cell or an auto transplant candidate? And if the patient is eligible for those approaches, you really want to get the patient to those approaches because those are the best established and still curative options, albeit in a smaller fraction of patients. If the patient is not a candidate for those approaches, then you have a range of different options. The bispecific antibodies are becoming more of an option. They are kind of a CAR-T cell light. One could argue a smaller fraction of patients could have long-term remissions and even cures with bispecific. I think there's still an option and probably more practical for some people in the community to administer, particularly if patients are a distance from a CAR-T cell center and may not want to travel, but they are still not without their complexities. We've also seen a number of different bispecific plus chemotherapy options that have come out recently. There's been a GEMOX Glitamab study, for instance, and several others out there. We've also seen Mosunetuzumab and Polatuzumab out there as well. So a number of different bispecific antibodies. Eparitamab with lenalidomide is a different example. And then Rituximab in particular has been useful as well. So lots of different combinations. Where you sequence really depends on whether or not the patient is going to be a CAR-T cell candidate. Then you're cycling through the options to try to get some durable responses for the patient.
Wow, there's a lot to unpack. That means we have more options, which is great. But again, out in the community, John, the question is, how are you picking one over the other? These patients have potentially two options of Axisel, Lysel. Also, this story, Rohit, you touched on ASCO 2025. How close are we of CAR-T actually becoming a reality in outpatient settings?
Yes, I think we're getting there. In many settings, it's becoming shorter, the hospitalization and the monitoring. There were just some updates in the REMS guidelines around CAR-T that make it a little bit more practical for patients. They have to, period of time where they need to stay near the center, and also as far as driving, which is a practical issue for many patients, particularly if they have to drive back and forth. That's becoming easier. I think we're seeing more and more outpatient CAR-T. I would say it's not the norm, but I think it is getting there. And I think as people get more and more comfortable, that will make it easier and more practical for patients. But most of the non-patients are having at least some hospitalization with CAR-T cells.
And then, John, can I push you a little further on this idea, Lysel versus Axisel? When that patient is in front of you, how are you making that decision one over the other?
Yeah, I think, and I think this is something that the CAR-T cell mavens have some nuances around. I think the time to getting Axisel and the practicalities of getting it are a little bit, in my experience, a little bit easier than the other CAR-T cell products. On the other hand, Axisel tends to have a little more toxicity in our experience. And so depends on how quickly you need the drug. If you can wait a little longer, some have argued Lysel might be easier for the patient, but if you need it quickly and the patient is sicker and has worse disease, Axisel might be more reliable. But these are very kind of soft things. And I think unless you're giving the CAR-T yourself, it really comes down to the center and the practicalities of the center and the preferences of the CAR-T physician. So I think for most people, if you're referring, it's really just kind of getting the patient on board with the concept of a CAR-T, because they're more similar than they are different.
And actually the same question here for bispecifics as well. We're going to get a chance to focus on bispecifics as part of another challenging case discussion with Dr. Telegraph and Carla Casulo. But in your practice, John, between Eparitamab or Glitamab, any nuances or anything out in the community that we should keep in mind when we're picking this?
The one difference for some people in the community is that Eparitamab has an indication both in follicular lymphoma and large cell lymphomas. It might be easier for you and your nursing staff to use one drug for multiple indications as opposed to, for instance, Mosunetuzumab in follicular and Glitamab in large cell. That may or may not be a factor. There are some nuances in the timing of therapy, the dosing frequency, the route of administration, the indefinite versus time-limited approaches, although obviously there's some nuances to, how the patient is doing and do you modify the regimen a bit. Again, Absolutely. I would highlight that these are more similar than different. Those may be some practical things that for people who are not doing this very often might make it a little easier for them to be familiar with one versus the other.
And John, with multiple options here, after CAR-T, the disease was to progress, are you going to rely on bispecifics or still consider utilization of Pola-BR or Tafa-Len just to get an idea about the sequencing here?
I think this is a cycling issue. We do have data that patients can respond reasonably well in some cases to a bispecific antibody after progression from a CAR-T cell approach. I think as we see more and more bispecifics used earlier, even upfront, it'll be interesting to see, can you retreat if the patient had a good response before? That will be an issue to keep an eye on. I think Tuximab is an interesting agent. We also now have some combinations with Polatuzumab and bispecifics, particularly Polatuzumab recently presented with some interesting data. The Tafa-Len is also an interesting approach for some patients. Most of these patients are probably not going to be cured of their disease if they relapse after CAR-T. So what's practical for the patient, what's familiar to the physician, most patients are going to get a number of different options over the course of their subsequent time dealing with the disease.
Thanks, John. Before we close, any important clinical pearls for us in the community settings with regards to the side effects, ICANS or CRS, especially when a lot of these patients are being monitored in tertiary care center initially, whether that's for CAR-T or bispecifics. When they go out in the community, what are some of the important things that we should look out for? And what about infections and prophylaxis?
Yeah, that's a great point. People are familiar with the ICANS and cytokine release issues. I think we're all tuned into that. I think one of the issues that we're getting more and more recognition is the chronic immunosuppression, both after CAR T cells and bispecific antibodies. One of our fellows, Herman Van Bezian, just did a meta-analysis looking at both bispecific and CAR T cell studies and showed that both groups had significant immunosuppression long term. And even the bispecifics, who you might think would be a little bit less immunosuppressive than CAR T, actually, because of the duration of therapy, may in some ways be actually more immunosuppressive.
Indeed.
And so I think the jury is still out, but you do have to keep that in mind. And I think a fair number of patients will require immunoglobulin supplementation over time. And I think that's something that community physicians are going to have to deal with, because this is a long-lasting sort of phenomenon, as we see in other settings.
Absolutely.
Indeed. Yes, we started off with saying that this is an aggressive disease, but we continue to learn more options here and get more approvals. John, thank you so much for touching on your treatment approach and how you manage diffuse large B-cell lymphoma today in 2025. For our listeners, let us go over a quick recap from today's discussion.
This discussion today, we've covered the evolving landscape in diffuse large B-cell lymphoma with Dr. John Leonard from NYU Langone Cancer Center. Should Polatuzumab be used for all comers, or should it only be reserved for non-GCB type? If so, in your practice, how are you confirming the origin of the cell type? Besides the discussion around Polatuzumab, we also had a chance to touch on options for our frail patients or the patients that have compromised left ventricular ejection fraction.
Though upfront treatment options are effective in majority of our patients, relapsed refractory remains a big concern given aggressive nature of this disease. We had a chance to touch on the data around CAR-T, including emerging data on CAR-T in outpatient settings, which was recently presented at ASCO 2025 on Axisel. Besides this, we touched on treatments such as Eparitamab, Glitamab, Tafelen, and Longity. Thanks for tuning in. Make sure to check out our new upcoming series around challenging cases and our ongoing conversations around treatment algorithms and tox check discussions. We are the Oncology Brothers.